The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors.
It's the Becky and Boca Show, coming to you live every Thursday night at 6 p.m. from glamorous downtown Boca Raton. I'll show you how to live life in style in one of the country's most elegant cities, nestled right along the beautiful Atlantic beaches between Palm Beach and Miami. So sit back, relax, and let me show you how to indulge yourself Boca style. Hello, welcome to the Becky and Boca Show. Tonight is a really, really special show. I've been looking forward to this. I had Leanne Hart-Deudo on my show about a month ago, maybe 6 weeks ago, and she had lung cancer, which had metastasized to her brain, and she had 12 tumors in her brain. Only one was operable, and she was given a diagnosis of 3 months to live if she didn't do any treatment. And she was recommended to do chemo and radiation. But they found out there was another treatment for her. So here we are a year and a half later. She's doing great, and I'm going to let her tell her story. And then after she tells her story, we also have her doctor here, her oncologist, Sajil Chowdhury. He's the medical director of Neuro-Oncology at the Marcus Neuroscience Institute, Lynn Cancer Center, Boca Raton Regional Hospital. And he is her oncologist, and he's going to tell us exactly what happened with this treatment. And we think we'll give a lot of people hope out there because she's very inspiring. So we're going to start with Leanne telling us her story, how this all started, how you were diagnosed, what happened. So you got to get a little closer to the mic here.
Thank you, Becky. Thank you. I guess it was February of last year, 2016, and Ash Wednesday, I had some numbing on the left side of my body in church at like noon, and really didn't pay any attention to it.
Okay, move a little bit
for about 15 minutes. And,
so it was like a tingling or numbing or?
Tingling in my face, my whole left side.
Okay.
So,
and up until this point, now you're a personal trainer.
Right. I had done a couple races and had some flashing on the left side, but really just thought that was, you know, from where I had been racing for an hour and a half, my body's tired and I need Gatorade.
Yeah.
So I didn't do anything about it Ash Wednesday. And Monday, the following Monday, I got up to take my son to school, and I picked up my dog's bowls and could not keep them in my hand. They kept dropping. So I was totally numb on the left side.
That must have been scary.
But it was. And I actually thought it was due to like a pinched nerve that I had from doing yoga. And I dropped my son off at school. It's a half hour later. And I called my chiropractor and I said, is this like a side effect of what I did at yoga? And he said, no, you need to get to the ER. If you're driving, stop. And so I actually drove myself to the ER, not advisable for anyone to do. And within an hour, they had scanned my head.
Within an hour, your life changed, as I understand it, correct?
Yes, night and day.
Okay, so the first thing they did when you went in there was a brain scan?
Did a brain scan and realized that it had to have metastasized from somewhere else. Because usually if someone has brain cancer, they'll have one or two tumors maybe, and because it was multiple.
It was a dozen tumors, correct?
Yes,
and one was quite large.
3 centimeters, and that was what was causing.
That's what was causing the
mini strokes on the left side. So they scanned my body and found the primary source to be my lungs.
So you actually had lung cancer, which metastasized to your brain.
Yes.
So what they were looking at was the later tumors, not the initial ones.
Correct.
From the lungs.
Correct.
So what stage was it?
Stage 4.
Stage 4 lung cancer.
Right. So.
Wow. And you found all this out within an hour.
Right. Yeah.
And I know after we had you on the show last time, you were contacted by one of the nurses that saw the show, and she was there that day up on the cancer floor, right?
Yes, it was her last.
And what did she tell you?
It was her last day on the 8th floor, which she said, I don't know if you remember me, but I was your nurse.
Did you remember her?
And I did. In room 836. I did not remember my room number, but she did.
She did.
So, yes, and she was so inspired. She had seen your show and always wondered how I was.
Didn't she tell you that she went home that night and cried over your diagnosis? This is someone
cried all
who has
weekend.
worked on the cancer floor for years, but your diagnosis was devastating.
Yeah, she was like, I can't understand how something like this can happen to.
And she knew you were raising a
someone
young
healthy.
son.
And yes, and stepchildren as well. So I'd really like to find her now. I've tried to message her back.
Oh, you haven't found her? Maybe we can find her on the show.
So many people have reached out to me,
I
and it's
know.
wonderful. And
You
this
got
is,
a lot of contact on
yes,
this.
this is a story about giving people hope and always being focused on, I can beat this no matter
People
what.
have been contacting me this week on my social media because I said that you're going to be on with your doctor. People that
Yes.
know people with cancer or have cancer,
Yes.
and they're very interested in this show
Yes.
because we're going to talk about some brand new cutting edge treatments.
Yes.
Okay, but let's go on with your story. So you got to the hospital. They put you up on the cancer floor. Then what?
Yeah, and then so I had brain surgery done the 3rd of March. So it was like the following week I went and saw Dr. Ricardo Comatar at University of Miami.
In Miami.
And he had a consultation with him, and he had immediately admitted me and did surgery the next day. I was released in 22 hours.
But you told me they couldn't take out more than one tumor? Is
Well,
that
they
right?
took out the large, the
the
3
large one,
centimeter.
the one that was causing the symptoms.
Yes. And I was eating chicken parm and cannolis that night, 3 hours after my surgery. Amazing. And I left the
felt
next
good?
day at 2 p.m. So,
But then what? Then
then, protocol was to have full brain radiation for the rest of the tumors and start like chemotherapy, which I was adamantly opposed to because I didn't have 1 or 2 tumors. I had multiple tumors.
okay, you had a dozen in
my
your brain,
brain.
and how many in your lungs?
4 to 5 sizable, and then my lung oncologist is Dr. Albert Vegas.
I know
and
Dr.
he
Vegas.
would say a snowstorm. I said, okay, so he says it's too many to count. He said up to 80.
So those were all little tumors that were forming.
He said it's like a snowstorm.
Oh, wow.
So it's non-smoker.
Yeah, I want to point that out. You were not a smoker. And I know people don't realize that, but you don't have to be a smoker to get lung cancer.
No, it's not choosy. Prep my food, ate very clean.
Personal
exercise-
trainer, exercise addict.
Right.
So you did everything right.
I thought so.
Yeah.
Yeah. So I had brain surgery, and I said before we start this journey on full brain radiation and chemotherapy,
Because you thought that would be very devastating.
I don't see. I'm 114 pounds. I don't think my body could have taken all of that.
Yeah.
So many people, So anyway, I got back, and 2 days later, I was supposed to start chemotherapy, and my pathology from my lungs came back, and I call it designer cancer, ALK rearranged.
Yes. ALK rearranged is the type of cancer that you have, right? And it's rare, I guess.
Well, my actual cancer is called
We'll get to the doctor in a minute, but
yes,
okay.
non-small cell carcinoma.
Okay.
And my pathology is ALK rearranged. Very, very rare. So that enabled me to take a targeted therapy drug instead of...
Because the drug matched up to...
Exactly.
We'll talk to the doctor about that in a minute. So I want to ask you to explain that. Okay, so this meant that you didn't have to do radiation or chemo.
Well, radiation, they still wanted me to move forward with. And
they did?
Mike Casper, Dr. Mike Casper.
I know him too.
I know him from cycling, and I said, Dr. Casper, really, I said, you have kids. I said, I'll never be the same. And he asked me to count backwards by 7. So I said, I can barely count backwards by 2.
Why did he ask you that?
So I said, it's just not for me. You'd have to. I would never be the same person. So
Yeah, it's scary.
I said, we'll just see how things go and take it from there.
Okay.
So here I am.
Here you are. How many? It's a year and a half later. Is
Yeah, it's
is
a
that
year and a
right?
half later.
Past your diagnosis, and your initial
No
diagnosis
chemo,
was
no
3 months.
radiation, lots of juice.
Yeah, I know we had you in here with Barry Rabkin from Raw Juice,
Yes.
and he was very
He's-
nice to support you through all of
Yes,
this.
Also one of my heroes.
Yeah.
And I still
Maybe get a little
juice
closer.
every day.
You still
Every
do.
day.
I know. I see all the
Absolutely.
posts of you at Raw Juice on social
Absolutely.
media.
And really tried to do plant-based diet, but it's hard,
Okay, but now tell us about your most recent scans.
I had a scan in December, that I guess it was the 1st of January. That was just a little bit of a slight change, but of course, in my mind, it was a big deal because it was not for the better, it was for the worse. But Dr. Chowdhury always said, listen, it's not even enough of a change it could be contrast, but it was enough of a change to get me to the Generation 3
The medication that you needed.
Yes.
Okay.
So I started that probably about 2 weeks later.
So this was just how long after your diagnosis?
In February. So it was like a year after my diagnosis, I started the new drug. There's 3 generations of that drug. And my scan in January, I still had 11 tumors. And March 1st,
gone?
I was clear.
In your brain and in your lungs?
My lungs were pretty clear in December.
Okay.
It was the brain that we were really trying to penetrate,
Wow.
It's amazing. So.
And you're still on this medication now?
Yes.
Okay.
So March 1st, June 1st, I was clear still. So it's good. It's a miracle.
It's good. I've had Leanne at one of my events, and the whole community just loves her. I mean, it's such an inspiring story, and everybody's here to support you.
Yeah.
So it's a great Boca Raton story. And now I want to introduce her oncologist, Neuro-Oncology.
Yes.
Dr. Sajil Chowdhury. And you're the Director of Medical Neuro-Oncology at the Marcus Neuroscience Institute, part of Lynn Cancer Center, and Boca Raton Regional Hospital. And Leanne, you were just fortunate enough to end up there and meet this doctor and others. And
my road was paved. The red carpet with all the physicians that I dealt with. Everyone, I was there today doing blood work. Everyone is wonderful in Lynn Cancer. Yes.
It's a great hospital. Okay, Dr. Chowdhury, you want to tell us? Why don't you take it from where?
Well, first, Becky, I'd like to say a few things. When I first saw Leanne, which was exactly about a year and a half ago, and I remember I just moved to Lynn Cancer Center and Marcus Neuroscience Institute.
Fortunate again for you, Leanne. All of these.
Just about a handful of months prior.
Wow.
And I received a consult in the hospital, came in to see her.
Was that when her initial visit, when she was just diagnosed?
Initial diagnosis.
Okay.
And I reviewed the MRIs before I stepped in. And sometimes you see a patient that the patient looks a lot better than the MRI did. So when I came in to see her,
didn't match up, huh?
Didn't match up. The MRI looked very aggressive, and
yes,
having seen these cases so many times before, you always have a bias. You always hope for the best, and I'm the ever optimist. You always hope for miracles, and you go in with every case thinking with a fresh mind that it will happen. You will win, and we're going to do this. But then humanistically, you always have this voice in the back, a little bit of the dark side, that what if that doesn't happen? So
looking at her initially, you were quite concerned.
I was very concerned. I remember when I stepped in, her
like
mom,
the nurse.
Yes.
Yeah.
Probably that's why.
So all these medical people were really
concerned. Yes.
Yeah.
So we have to be very optimistic, but also have to be realistic. So it's a perfect, harmonious balance.
So did you have to tell her, bring her up to speed on exactly what was going on that night or that day?
I did. I don't know if
you remember him talking to you?
I don't know if I was the first one. She might have heard it before, but at least we had a short but firm and good conversation about the MRIs. Yes. And even I remember going in and mentioning to her that there's one area that was largest. It was the right parietal area, frontal parietal, and it was more of like the non-dominant hemisphere. So,
and that's what was causing her symptoms. That's what brought her in.
That was causing most of her symptoms because they were left-sided sensory symptoms. So I knew stepping in that large one needed to come out.
Okay, get a little closer. Pull that a little closer.
And then the others were too small to remove. So
you would take out the big one and
leave. So our thought was that we removed the largest and then we addressed the smaller ones later. Mm-hmm. And so it was a tough but good initial conversation. Was
she cheerful and optimistic like she always is?
She was concerned, but she took it very well.
Yeah.
She was concerned, but she took it very well.
Wow, that's amazing.
I don't think I really
I could look closer.
realized. I
You were in
realized
shock.
that it was very severe, but it certainly wasn't at that stage where they said, this is what your, survival rate. I mean, and they don't say that, but without treatment, because I was like, no radiation, no chemo.
Oh, you were the one saying you didn't want to do anything.
Yeah. So then when I got 90 days, I was like, okay, I need to listen
Yeah,
to
maybe
these
I
people. And that didn't happen in the hospital. That was,
Well, it probably took a while
yes.
for you to wrap your mind around it
Before I
and
went to university.
really
yes.
realize what you were
Yes.
dealing with.
Yes.
Okay.
So after that, she went down to Miami, met Dr. Komatar, who's a good friend, and we, even though we're separate hospitals, but we work very well together, which is
Okay.
always a good thing. And
Right.
we can't all fight this battle ourselves. We
Right.
have to work together. And then soon thereafter, she returned, healed very nicely. Then we were at the second chapter, which is what do we do now?
Right.
We got to address the lung tumor that is producing all these, metastatic microscopic tumor cells. Plus, we have to address the remainder intracranial disease or inside the brain tumors. And hence, quickly conversations ensued about doing radiosurgery or, more like stereotactic radiosurgery versus whole brain radiation, pros and cons, whole brain, the neurocognitive
Now,
impact.
are both of those damaging? Would she have had some?
Both of them are damaging. Whole brain is certainly more damaging, if you will, and at times is very necessary.
Yeah.
And in her case, it seemed at that point that was the way to go.
Yeah.
And that's when our colleague oncologist, Dr. Casper, met her, and we talked about stereotactic radiosurgery, pros and cons. We spoke about whole brain radiation. And while we were speaking about all this, trying to wrap our minds around it, and hindsight is always 20/20, but at that point we made the decision based on the ALK mutation and the drug sensitivity, and that we should go on systemic therapy. But I would confess that Dr. Begas, myself, Dr. Casper, and were a little bit nervous and unsure about the future. And of course, it seems now that we made the right choice, and it's
Absolutely.
certainly been a lesson. It's certainly been a lesson learned for all of us that it's the example of individualizing oncology and more of like the personalized oncology. And
Well, that's exactly what this is, because that drug wouldn't have worked on everybody, right?
it would not have. And even with patients with ALK mutations, not every patient will respond that way. So
Right.
even though we might have 5 patients like Leanne with the ALK mutation
Well, what's the
positivity,
percentage rate? Like people coming in with her?
It's a small percentage.
That's what I thought.
It's a small percentage. And at an individual level, not every patient will respond as good as Leanne did.
So you were
So-
still not sure whether it was going to
Yes.
work at that point.
Yes. I remember when I was training, Becky, in oncology, we would speak about, more of like the pharmacogenomics was the term of the future, that one day, based on genomics of tumors and tumor biology and doing almost like the molecular profiling of tumor pathology, not just brain tumors or lung tumors or ovarian tumors, just to give a few examples, but all tumors are going to be molecularly profiled and based on.
And they're not now.
Well, we are doing it now.
Okay.
So when I was training, it was something of the future,
Okay.
but now we are living.
Everybody-
we
okay.
are in that future in
Yeah.
which we're able to guide therapy and individualize therapy based on tumor genomics.
Uh-huh.
So that's the emerging field and ongoing field of pharmacogenomics, in which we do our level best to match drugs and targeted drugs based on patients' individualized tumor genomics. And Leanne is the perfect example of that, in which her ALK mutation was taken advantage of. And she started a systemic therapy, did it very unconventionally, because convention would be to do stereotactic radiosurgery or
Yeah.
whole brain radiation and then do the ALK drug. But we went on a limb, took a little chance.
Because she didn't want to do
Because-
those treatments?
Yes, her choice, I would say, was first and foremost. Plus, she was doing so
She was
good.
doing well.
Again, she looked a lot better than her scans looked, which is always a good sign. So I don't recall Dr. Begas and I having this conversation, but in both of our minds was, well, we might have a little room for error here. We might have a little margin to kind of take a chance here,
Yeah.
as she wasn't clinically declining,
Mm-hmm.
and we felt we might have some room to take a chance. It's like a football game. You're ahead
Oh,
of the
wow.
other team, so maybe you can lose a touchdown and maybe still have a chance
And
to
still
come back
recoup if
around
you had to.
and win the game.
Yeah.
So we thought that maybe we could take a chance. And I am a believer, but I would say that I was a little bit nervous about what the outcome would be. But again, hindsight is 20/20.
Yeah.
It's a good story.
Oh, it certainly is.
You certainly
believe
wouldn't know that he was nervous about it because
Yeah, well, they have to, yeah. So he
optimistic.
presented a very optimistic
Yes.
view.
Yeah, you know.
But this is interesting because now we're getting his side
Well,
of what he was thinking. And
And
he
the
was,
severity of my diagnosis, my insurance would not approve the Generation 3 drug. They said she needs to start at Generation 1. But do you know what? Generation 1 lasted almost a year. And probably, it kept me status quo.
Okay, so you took Generation 1 first, and then you were upgraded?
January, yes, when
Okay.
there was a slight change in my MRI of my brain. And they jumped me from level 1 to level 3. So I get to skip number 2.
Wow.
I recall when we were reviewing our MRIs, and almost every MRI that we did, that Leanne was very interested to visualize the images. So we would
She seems to really be on top of things here.
we would walk back to my office and review the films. Often she would have family and friends with her. And I always felt that there's an element of seeing a little bit of like the pseudo-progression effect. It's a term we use very commonly in oncology these days, in which you can see change in tumor size on MRI, but it might be inflammatory effects of basically, it's basically necrosis, and you see this pseudo-progressive effect. It may not be, it's not true progression.
Okay.
So on some MRIs of Leanne, I felt that I was seeing pseudo-progression, so we stuck our course and we stayed on the first generation. Wow. But then there was one MRI that we did that there was distinctly in one area, there was there was more increase than we could be comfortable in just continuing to watch. And that insurances are very cut and dry, so the overall thought process was that if we see progression, even if it's intracranial progression, it could justify us to go to a higher.
So how does that work? Do you have to petition the insurance company to get her on the next drug, or?
Many times we have to, Becky. And they will come back and ask, well, what's the reason of going from a lower generation drug to higher generation drug? Usually it's all about cost, because newer drugs are more expensive. But when they see in our documented notes, every time I see a patient, or Dr. Vegas or Dr. Casper and others, we always dictate a note for that day, which is sealed in stone. It's more of a medical record. Then often we'll have to send copies of those medical records, and there's great staff working up at the Lynn Cancer Center and Marcus Neuroscience Institute that are working behind the scenes, a little bit of the unsung heroes, if you will, who filed that paperwork behind the scenes.
Right,
sometimes
because it's a lot of work to do all of that.
It is. A lot of faxes getting lost, and
I know.
Finally it happens. Many times it happens.
And can I ask you, what if she didn't have insurance? What would have happened to her?
If she had no insurance, then we would have been, I agree, Becky, we would have been a little bit more stuck, if you will.
Yeah.
But most likely we would have still fought for her. And sometimes pharmaceuticals, I know we can say a lot of negative things about the cost and everything, but there are many things that they do that are good. And many of the insurances, many of the pharmaceuticals have these special patient assistance programs
in
which, in special occasions, in special circumstances, if you have to plea and you have to beg, and all of us have been on the phone many times.
That's wonderful that you
speak with the
do
medical,
that, because I know how frustrating it is. It's like if you call in on a 1-800 number for a product or something, and they put you on hold and they transfer you around and they don't call you back. And I know that happens with insurance.
Yeah. So often, Becky, will have to, and they make it harder, and they're trying to find reasons to default.
Right. Sure.
And so often they'll say, unless the MD doctor calls, we're not going to approve it. And then most of me and my colleagues will find the time to get on the phone.
Wow. Busy doctor, and they actually have to get on the phone like that. And And they do it.
They do, you know, and it's amazing because that drug, I get the invoice for it each month. The Xalcori that I took first is really the same price as what I'm taking now. The price, if you did not have insurance, is like $14,870 something dollars, and this
Per
drug
month?
is per month.
Oh my.
So if you didn't have insurance, I'd love to think that these drug
That they would,
companies would assist, seeing that even the people that are able and eligible to take this drug, if they didn't have
Are there people that are eligible that aren't getting it?
So in some cases they are, and those are the patients that are basically uninsured, and we, so I would say there are two elements there. One is they need to be with a oncologist or a physician's group that is willing to fight for them and go the extra yardage and pick up the phones and send the faxes, and staff working behind the scenes, and most good centers, physicians are that, and they do that. Maybe in some that doesn't happen. The second thing is, does the does the pharmaceutical company have a patient assistance program that's user-friendly, that actually will make things happen? So you need a pharmaceutical that is willing to work with you. You need oncologists and offices that are willing to go the 9 yards. And
See, I think
and
people
fight
don't
for their
realize how
patients.
important that is until you hear a story like this.
You know, I always say that as a patient, and when it happens for the first time, like in Leanne's case and many other thousands of patients every day, there's no instruction manual. You don't really know how it's supposed to be done, and it's so important to have a physician and oncology group, an oncologist, or a cancer program, or a neuroscience institute that the docs really have passion, and they're very sympathetic, and they will really mean what they say, and go the extra yardage.
And you certainly did for Leanne.
Which they both, yes.
Fantastic.
Everyone, yes.
We're going to go to break here in a minute or two, but we can keep talking until they tell me. Okay, I have a lot of questions. I'm going to wait till after the break for my big one, but I want to know. We're going to go to break. I'll ask you afterwards, because it's kind of like a 3-stage question. Okay, we'll be back in a couple minutes. And now, back to the show. Hello, welcome to the second half of the Becky and Boca Show. I'm here with Leanne Hart-Dayuda and Sajil Chowdhury, medical doctor. He is a neuro-oncologist, and he's treating Leanne. So the question I was waiting to ask, I wanted to wait till after the break, is, Doctor, is this a cure for cancer? I know that's a big word in cancer, but are we seeing a cure for cancer?
Becky, I would say that in this unique circumstance, with this one patient with a unique, genomic alteration, and as I was mentioning earlier, that even with these, genomic alterations, if we had 5 patients with the same genomics and we implemented the same drug, each 5 of them are going to respond differently. So we think there's something beyond that we don't understand, and with time, next 5-10 years, we're going to
figure that out. So you think there's another variable?
There might be many other variables, and some of us argue that at most of the national meetings we might be scratching the surface. So we got very lucky here, and that not only the drug matched at like a pharmacogenomic level, the drug matched perfectly, but there is something hidden, something secret underneath the surface that we don't know, that it matched even better than what we initially thought. And we sure hope so. We can do this to many of our patients every day. Wow. And hopefully we're going to do this.
So we can call this a cure.
So far, we can call this a cure.
How do you like that,
Good
Leanne?
news. That's good news.
No, but that's big, because people are very cautious to say that when it comes to cancer. But I know with everything that's happening now, all these new drugs, all these improvements, things have really changed in like the past couple of years, right? I mean, how new is this treatment?
We've been using these ALK mutation drugs for, I'd say, about 3 to 5 years or something around that time. So in the world of oncology, that's very new. And the newest agents that we are using, and one of them Leanne is on, is probably in the past 1 to 2 years.
Wow.
Now, they might have been in phase 1, phase 2 trials or phase 3 trials, but FDA approval level has only been a handful of years. So they're very new drugs.
Wow. That's incredible. Have you ever had any other patient with a severe diagnosis as Leanne that has responded like this?
I can remember one other patient with a different tumor primary with brain metastatic disease that did respond to systemic treatment so well. Now, there are a lot of new drugs emerging, and there's new drugs getting approved every 1 to 2 months.
Wow.
I feel, and maybe my ever optimist self, that we're going to see this a lot more.
Oh, that's
and we sure will.
fantastic. I have been contacted by a lot of people that have or know someone with brain cancer. But now Leanne did not have brain cancer. She had lung cancer metastasized to her brain. Is there a difference, and would these drugs work on someone with brain cancer?
Good question, Becky. So I agree. It's always very prudent to make that distinction that her tumor was not a primary brain tumor. So primary brain tumors are tumors that come from the brain itself. Hers was more of like a secondary brain tumor, being that the cells micrometastasized and originated elsewhere, lung, breast, renal, or kidney, or melanoma, etc. So yes, we have to divide the line there. That these were more of the metastatic brain tumors, or more of the secondary brain tumors.
Does
Versus
it work on
brain
primary
tumors.
brain tumors?
So this particular agent, I'm not aware of that it's being tested in primary brain tumors. Now, you are right. There are some drugs that work on metastatic or secondary brain tumors that also can work on primary brain tumors. So there can be an overlap there. But so it's a two-part answer. Some of these drugs will only work on like the metastatic disease, but there are some that may work, or there are some that only work on the primary brain tumors, but there are some in the middle that might work on both.
Okay, but her lung cancer was her primary cancer.
Yes.
And has that dissipated too?
That has.
And is it from these drugs?
Absolutely. Actually, her primary lung
exciting.
disease responded the first. And
Really?
we've always fought this historical battle of there being almost like a barrier between the blood and the brain. And then there's a blood CSF barrier, which is the spinal fluid. And since day and old, since I was training and doing my fellowship, we have been publishing and writing and reading and researching that how can we bridge the gap and break down that barrier and push drugs more effectively across the barrier from the blood into the brain. Luckily, some of the newer agents, not all of them, but some of them are very easily accessible. They cross that, blood-brain barrier very easily. And then sometimes with brain metastatic disease, the blood-brain barrier is broken down.
What exactly do you mean by blood-brain barrier?
So, it's the brain is a very protected organ, a very protected structure. So even some of the chemicals, normal, chemistries in the blood can be harmful to the brain surface. So there's a natural protective mechanism of separating the bloodstream, in very simple terms, separating the blood chemicals and the contents of the bloodstream, separated from the brain surface itself, and only let certain items cross that are helpful to the brain. And now, because of that mechanism, it's kind of like a filtration mechanism, a super filtration mechanism.
Wow.
And because of that, normal conventional drugs, it's been an age-old question, are not able to cross that blood-brain barrier. So some of the conventional chemotherapies we've been using for years, we feel that maybe only 10-15% of the drug actually will cross the blood-brain barrier.
Wow.
So we've conventionally, or we've historically felt that brain tumors or metastatic tumors find a safe haven, if you will, that they're protected from the body's immune surveillance. They're protected from any chemotherapy we intravenously infuse.
Wow.
And so we've had frustrations and challenges in treating brain metastatic disease.
Wow.
But luckily, with some of the newer agents, we've been able to bridge that gap.
So you think things are changing, and there's
things-
going to be improvement
things
even
are
with people with
definitely
primary
changing.
brain cancer?
Yes. I often get the question, as you might have heard, and Leanne must have heard, that often comes up that, are we really making strides? Are we really curing these tumors? And I truly feel that even in my 15 years of working and doing oncology, a little bit more than that, I've seen big strides.
You've actually seen.
Yeah.
Will she have to be on medication forever?
Good question. Now,
And will her insurance pay for that forever?
the insurance will
That's
pay
another-
for it. So there are a lot of clinical trials, and some of them we're doing at our sites that are phase 1, phase 2 trials, mostly phase 2 trials, phase 3 trials. We do very limited phase 1 work, but some of the trials are written that as long as there are two necessities, as long as there's no tumor progression, which makes sense, as long as patients are tolerating the drug reasonably well, so their liver functions are good, kidney function.
Oh, you have to test her for all of these things. Okay.
Exactly. She has lab work very frequently, as long
Today.
as exactly. So as long as the body is holding together and the patient is first do no harm. So as long as the body is holding together and the tumor is responding, many trials state that you stay on the drug forever.
Stay on it.
And
If she went off of it, would she have a reversal?
So that's a big leap of faith. So
You don't know. Okay.
Often I counsel patients that I will abide by their wishes. Let's say, hypothetical figure, we do this drug for 2 years or 3 years, and a point comes, not Leanne, but another patient in a similar scenario says, I want to come off it. So we'll have to have a good conversation that day.
Why would
the
someone
pros
say
and
that,
cons.
though?
Sometimes it's personal choice. Sometimes the drug might be causing some side effects.
Oh, yeah,
but
I was
it's
gonna
not,
ask you about
it's
side
not
effects.
so severe. Maybe they're just very fatigued and very tired,
Mm-hmm.
or they're just tired of taking several pills a day and they just wanna come off it. And it'll give them a psychological advantage that now they're in remission because they're off the drugs. But I
So-
agree with you, Becky. Many patients will not say I want to come off it.
Yeah, I
because-
can't imagine if it's working. Why
because
am
there is a
what?
risk if we come off it. Nobody, if that point comes, maybe not here, Leanne will choose, but if that point comes with another patient, I will certainly have to counsel that there is a hypothetical risk that
Yeah,
the tumor
I would think
could
so.
come back.
Now, do you call this remission, what she's in, or do you call it a cure?
I would comfortably call it remission.
Okay.
Now, the words cure they're very loose terms, and I believe that none of the academic community has answers. So we make up our own answers. If we've been doing this long enough and doing
Yeah.
clinical trials and we've been in the field, my personal persona is it's been 2 years. We're going to be it's going to be a remission, and we're close to 2 years.
Yeah.
But I usually say, now don't hold me to this. I usually say if it's 5 years and no tumor has come back, I'd call it a cure. But we're going to follow. We're going to keep an eye on
Sure.
things.
And this is very exciting to be on the beginning edges of this kind of medicine, I would imagine, for you, seeing results like this, where a
Yes.
few years ago you didn't see. If this had been 5 years ago, what would have happened to Leanne?
This was 5 years ago. We would have persisted further that Leanne should have had whole brain radiation or stereotactic radiosurgery. And even if we did stereotactic radiosurgery, likely something would have progressed afterwards and she would have needed whole brain radiation. There would have been the neurocognitive impact of it.
Yeah, I imagine so.
And Leanne's and similar patients' amazing quality of life currently would not have been there. Quality of life meaning time with children, time with spouses,
Sure.
time with parents, families, and traveling and doing all the things you enjoy in life. So things could have been a lot different.
Yeah. So, okay, talking about quality of life, she looks great to me, and she always has. How do you feel?
I feel great.
Is there any side effects from these drugs? Here, get a little closer to your mic.
You know, I'm a little tired because I've done a lot of traveling this summer.
I get tired too. That's like,
I've been in an igloo. I've been in my little
I know you
for
climbed
15
that mountain
months.
and all sorts of stuff, didn't you?
I did.
So it's not like this drug is wiping you out or anything like that.
No, but my stamina is not what it used to be. I had to take a day off. I listen to my body now, and I don't train every day. I take a lot of naps still,
Yeah.
and I recharge. So, but my quality of life is back, like
Yeah.
100%, and it's never giving up hope. having a positive attitude no matter what.
Yeah, doctor, do you feel that's important? Because she's one of the most positive people I have ever met. In the
Very
face of all of
important.
this adversity,
Very
she's
important.
smiling, saying, I got to give back, I got to help people.
Yes.
That's unusual.
Very important. Not only important for all the patients walking in our doors, but it's important for all the oncologists and all
Right.
the staff in the cancer center, that even in the face of not knowing which way things will go, but just kind of suppress those feelings and always think, as tired as you are, that we will win and you will win.
Yes.
And you keep fighting. Because even if you lose, that's the only way to do it.
Yeah, right.
You
Well,
have to
fighting.
go
What choice
down.
do you have?
You have to go down thinking you're going to win. And that's the only way to
Absolutely.
be.
Did you ever get to a point where you just thought this isn't going to work?
I had some valleys, you know. I definitely had some valleys, but you know, you got to stand back up and start walking again.
And you had wonderful doctors behind
Great
you and all the other
oncologist,
people at...
Barry from Raw Juice. I started
Yeah.
juicing from day one. I can't
I
possibly.
know. I like
eat-
how the whole community rallied around you. That's fantastic.
They're great. The staff there is amazing. And
Yeah.
if it weren't for Barry, I probably still, you know, would not be able to keep up with that. But I plan to. I will do 3 green juices a day if I can, and turmeric, and keep up that regimen, because a plant-based diet is great for Barry. I just am not good at it.
You know, you like to have a little meat every now and then.
Once in a while, or fish or chicken, and but primarily, yes, I eat, you know, salads and eat light.
Well, I was going to ask you about that. Does diet during this treatment have anything to do with the outcome or the how the person feels? I mean, is that important?
You know, Becky, I must confess again, I may not have been a believer in this, you know, when I first started, but I do feel there's a lot of role to play. And you know, we need protein. If we're under the treatment
Right.
of, you know, chemotherapy, conventional chemotherapies, radiation, recovering from surgery, or clinical trials, or more of a targeted agent, whatnot it be, we need protein to be able to regenerate
Energy.
our skin cells and muscle cells, and you know effects of on like the bone marrow reserve and liver and kidney. So protein is very important. Vitamins are very important, and so I always counsel that. I always say that take in a heart healthy diet with extra protein.
Extra
Because
protein, okay.
if patients do that with a heart healthy diet, which is going to be good, and anyways, it's good for all of us.
Mm-hmm.
And with protein and, you know, multivitamins, it can only help.
Okay.
Absolutely, yes.
Okay.
I remember him saying to me at one point in January, "Go eat a burger. You're getting too skinny."
Yeah, go eat a burger.
Yes. I'll often tell patients that, hey, I can't go have a milkshake and a burger, but you
can.
And especially our patients lose weight, and
Yeah.
there's an element of, you know, depression, and we all react differently to feeling sad, and some of us eat more when we're sad, but in my experience, most of our patients eat less when they're sad. They don't feel like eating.
Yeah, sure.
And there's also
A
a
little
taste.
depressed.
Yeah, there's a taste alteration effect of
Oh,
you know, chemotherapy, systemic agents, and radiation, and
but you didn't have any of that with your targeted
No,
therapy,
no,
right?
Thank goodness. Yeah. Thank
Wow.
goodness.
Tell me a little bit more about insurance approving these drugs. In the beginning, when it's a brand new drug like that, do they have to cover it? If it's just FDA approved and brand new, is it a choice
So-
by the insurance companies?
most insurances, if it's FDA approved and if it's embraced by like the National Cancer Guidelines, they are like the NCCN guidelines that most good cancer programs and hospitals follow, and we follow those guidelines. When the FDA approves a drug, it's not necessarily part of the NCCN guidelines, but most of those drugs, if not all of them, eventually become part of the NCCN guidelines. And it's very difficult now. Again, we know we hear a lot of negatives that are happening with this whole, you know, business, if you will, and apologize for calling
It's
it
too
a
bad
business.
that a business
Seems
has to be
like it.
involved in
Yeah.
getting her the
Yeah.
drugs that she needs.
There's
but
a lot
that's-
of, you know, we can say a lot of, you know, negatives about it, but the other positives are that if it gets FDA approved and embraced by the NCCN, it'll be very hard for insurance companies to refuse. those
it.
drugs, yeah.
Okay, so if there is somebody that really
yeah.
needs it and they are insured,
Drug for
They'll most
that,
likely get
yeah, for that indication. Now, Becky, second part to your question would be that what if it's a drug that's approved for a primary brain tumor, but not approved for a metastatic tumor, or not approved for another tumor site? Let's say it's approved for ovarian cancer, but not approved for breast cancer. Then what do you do? And that situation arises very, very commonly. And that's where things get a little bit fishy, if you will. And then because sometimes the tumors have the same genomic alterations, and if you do more of like the molecular, if you look at the molecular pathology,
So you're saying it would work for other cancers too, that it's not approved for.
But the clinical trials have not been done.
Right.
So the insurance companies come back and say, well, we have an out. The FDA has not approved it. And sometimes they're actually orphan tumor types that are, meaning they're very small population of patients.
So nobody's testing on them.
Nobody's doing trials on them.
Well, that's scary.
That's where it gets complicated. And then that's where, again, highlight that you need to be with, and we need to be with an oncologist or oncology group, or group of not just doctors but nurses and healthcare professionals who are a good team and who are gonna fight for you.
Right.
And those
I
people
realize
can
that
go
now
out
that makes a big difference.
and sometimes you can make a case and write letters, and it takes effort. But if you go the extra yardage and you say, well, just an example, that this may not be the tumor type that the drug was originally approved for, but if you look at the molecular profile, it's very similar. I, as the oncologist, feel that this drug could work, and you have to write letters, you have to pick up the phones.
It's a shame that you have to do that, but I understand that.
Yeah, it takes a few weeks. And then sometimes some pharmaceuticals insurances will, and yes,
Well, you do it.
at times
So
they'll say no, but
it's like
sometimes.
using a drug off label, and
like
a lot
using
of
a
drugs
drug
are
off
used
label.
that way.
Yeah.
So, okay. Now, if somebody's watching or listening to us and they want to find out if they're eligible for these targeted therapies, these new therapies, what do? They have to go out and find the right doctor? Are all doctors aware of this? Is it?
Most are.
Okay.
in good academic centers or good centers are aware of all these drugs. So they should, wherever they are, wherever they live, find a good center, a good oncologist, and we do so much. We check so much these days. We call somebody to work on your house. You check it. So find a good center and a good oncology team, and most likely you will get the
You'll have
same
access to the same medications.
Like I said, I wouldn't want to have been diagnosed 5 years ago.
No, that's really scary. That I mean, not scary for you because
Well, it's cutting edge,
I
It
know
really-
that's why it's so exciting, and that's why I want to do the show, because we got so much interest last time you were on, and I mean, you saw how many people viewed it and contacted you, and
I've spoken to a lot of people, and
you give people hope. Let me tell you.
yes, and and it's probably 3 or 4 people a week. I'm talking to like 6 people right now, and
Are these people that have cancer?
yes.
Yeah.
And it's either by your interview, they've messaged me, or it's a friend of a friend that has seen the interview. And
Yeah, we put it out there on YouTube too, which I'm going to do with this one also. So
A woman in
hopefully we can
Maine.
reach more people.
Yes.
Woman in Maine contacted you.
So
Wow. And what do they say?
they just want to talk about my experience and my treatment, and what did I do that's differently from what they're
they
doing?
did, yeah.
And it's diet. I did do a little bit of alternative therapies, and I just never gave up hope. I mean, I really placed my trust in my oncologist and my big physician.
I know you're a very hopeful person, because the last time you were in here, you had a brain scan that morning. You did not know the results.
Did not know.
But you said, I'm sure it's good. I'm thinking, how does she know that?
Thinking I had 2 little spots left, and Dr. Chowdhury said, those aren't spots, so they're your blood vessels.
Oh my goodness.
it's-
So her brain scans are completely clear now.
Our brain scans are looking fantastic, very good.
So it's
You still
lines.
see some shadows of the previous tumors. You still see some of the post-operative change from that right-sided tumor that was removed, but it's looking dramatically better. And knock on wood, we hope that we're going to continue that for a long time.
Yes.
Yeah, I think you will.
Yes.
So Okay, so she'll stay. Her course of treatment will be to stay on this drug. You'll keep scanning her, and hopefully, and I believe.
I do.
You're gonna be fine.
We've just started to dose my Keppra, which is a
What does that
seizure
mean?
medication. Try to wean myself off of that to see, what will
Oh,
happen.
you take that?
Keppra every day, twice a day.
Okay.
So far now, I didn't tell him this. While I was traveling, I stayed on it because I was climbing mountains. I was
Yeah.
changing time zones, and I said, I don't want to take that chance. So I
Right.
just started doing that this week since I've been back. But
So you'll
yeah,
wean
so
her
far,
off of that.
So eventually I will, and that's a good question. There's, even if one has never had a seizure, just having brain tumors in the brain, it's a little bit of like an abrasive effect. The brain
Sure.
doesn't like it, and brain is such a fragile structure, so the seizure risk is high, and so I'd like to keep her on it a little bit longer, and hopefully we'll reach a clear.
Had she had
bring her up.
seizures at one point?
Well, the flashing, he said, was
Was it?
kind of
Okay.
like a mini.
Yeah, focal seizures as we call them, and so we're just being safe. And Leanne still has a very active lifestyle. She has a young son. She
I know.
drives. God forbid you have a seizure, then according to
Right.
the state law, you can't drive for a long time.
Yeah.
So we're trying to avoid all those
Right.
complications. Yeah. So one of our job as a good oncologist is, and we work as a team. It's not just me, but Dr. Becky.
Yeah, I know that. It's a nice group.
Yeah, we're trying to pave the path for her. Not only look at the past and the present, we're happy about, but we want to keep looking at the future. It's almost like a football game that the coaches has to keep fighting and not get too happy by the score, and just you got to play all four quarters. So we're playing all 4 quarters.
So she will be your patient indefinitely, correct?
Hopefully, yes.
And how often do you have to see her?
Well, we're doing MRIs every 2 or 3 months
3
now.
months
Yeah,
now.
3 months
So my
now.
next one will be September
So-
1st.
Yes. But I often will see her in between for just more of like a clinical follow-up, and I tend to follow my patients a little bit more frequently. And so I'll see her maybe every 4 to 6 weeks, be just a clinical visit in between. Then I'll see her with every MRI report, and we'll review the films.
And I see Dr. Vegas on Monday, so I haven't
Yes.
seen him for 2 months. He says, you're boring now.
Yeah.
Which is
So-
a good sign.
Are you
It
scanning her
is.
brain and her lungs every time? Is that what happens? Or
Not every 3 months. She's getting CAT scans of the lung as well on a regular basis, and
because that was the primary, right?
That was the
But you said
primary.
those were the first ones to dissipate from the medication.
Those
right?
were the first ones. Yes. Yeah.
That's an
It's a miracle.
It's an incredible story. Well, it's a miracle, but I think what he's saying is we're going to see a lot more of this, and there's a lot of hope now for
Yes.
people with cancer that wasn't here a few years ago,
Yes.
which is very, very exciting. And are they using these targeted therapies for all different kinds of cancer too?
So there are a lot of agents now, and we are certainly we are a field that we are certainly very blessed that now there are drugs for many different tumor types, many different tumor sites, and not all work as good as the others. And there's also an intervariability between patient to patient, but there's a lot of good agents out there. So I believe that our message should be a message of hope, that things are getting
It
better.
certainly is a message of hope. Absolutely. And, there's a lot of people that didn't know these drugs were out there. And I think it takes a lot of fear out of cancer for people now to know that, it's not hopeless.
It's awareness.
That's
it.
And I
Yeah.
really didn't even think that was an option. I had forgotten about my pathology. So just always ask questions. Have hope. Go to Raw Juice. Meet me. I'll meet you there.
There you go. I know you're always
Yes,
posting about it.
yes.
And find some good doctors like this
Yes,
one right here, Dr.
yes.
Chowarty. This is incredible what you've done. Thank you so much for coming in and talking about this. You're going to give a lot of people hope, and you gave us a lot of good information.
Thank you.
And,
Thank you for having me.
She's wonderful, isn't she, too? I mean,
Yes.
you got to have a good patient.
Amazing.
To,
I'm
She
still,
is.
I'm still just in awe. Yes, cannot believe what's happened in 15 months.
It's a great profession. I have a son that just started medical school, and stories like this are just so inspiring. It's like I feel like, okay, now he can go out and do things like this and just change the world.
Yes.
Okay, thank you. We're going to go. Thanks for coming.
Thank you.
You have been watching and listening to The Becky and Boca Show. Tune in every Thursday night at 6 p.m. to discover all the ways to spoil yourself and have a good time in beautiful Boca Raton. See you next week.